talking about something so important and could kind of drag us down. It's important to have the good experts in the room. We're going to be talking all about sleep and how to maximize the benefits of sleep, get the most out of that time when you are in bed. So let's run through. We've got a few slides, a few bio slides. I've got Dr. Rose running the slide deck for us today. Everybody works around here. Nobody gets off easy. So we'll click on through. The next one will be my bio. We'll skip on through that one. Let's get to Dr. Rose. So let me introduce Dr. Mary Rose. Dr. Mary Rose is a clinical psychologist who has worked in the field of sleep disorders for over 25 years. She's boarded in behavioral sleep medicine by the Board of American Sleep Medicine and licensed in the state of Texas as a clinical psychologist. She currently owns a private practice, Rose Family Health Psychology. She additionally functions as director in the Department of Sleep Medicine at the Menninger Clinic and is an associate professor in the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. She received her doctorate from the Virginia Consortium and completed her internship at the University of Texas Medical Branch in Galveston. She completed fellowship at Shriners Burns Hospital for Children and UTMB, an additional fellow training in sleep disorders at Michael E. DeBakey Veterans Hospital in the Pulmonary and Sleep Department. She's authored and co-authored 24 peer-reviewed publications and over 40 other book chapters, reviews, and manuals. She lives with her 9-year-old daughter, a schnoodle, and a dwarf rat. I feel like that alone, we could have a session. We could talk about all those things. Thank you so much, Dr. Rose, for being here. I also want to introduce my colleague. This is somebody I've worked with from the day that I walked in here at Alliant Group 6 years ago. Melanie Baxter. She's our Senior Director of Strategic Communications. Oh, gosh. That is my title. I'm sorry to give you my title. Look at you. No, that's me. I didn't skip ahead. Melanie Baxter. She is our Senior Director of Investment and Wellness. We might as well call you a Senior Director in Communications because you do a lot of our talking around here, a lot of our talking, but all good things. She's a native Houstonian and retired professional ballerina. Melanie has always had a passion for health and wellness. After spending the first part of her career in corporate education for LVMH, which is Louis Vuitton Moet Hennessy, she attended graduate school to study health and wellness and obtained her master's in exercise science health promotion with a specialization in corporate wellness psychology. Melanie is passionate, and when I say passionate, I mean real passionate, about helping people live their best lives by successfully integrating work-life success, leadership development, and nutrition. Melanie's research on workplace wellness led to her to develop innovative programming for national employer wellness groups at Humana and was recognized as the company's Employee of the Year in 2016. Currently, Melanie leads Alliant Group's multi-award-winning wellness and investment team that focuses on all areas of corporate wellness, including physical, intellectual, situational, occupational, emotional, financial, spiritual, and social wellness. You've got a for sure full-time job. So thank you so much, Melanie, Dr. Rose, for joining with us today. So I want to get to go to our next slide because we were talking a little bit about this when we started. So this slide is not some stock image. So talk a little bit about that, Dr. Rose. So grab your mic for me.
I wanted to talk largely about, because it's a women's group, I wanted to talk largely about the sleep of women and things that can go wrong, things that go right, and how to make things better. And so this is a picture of my daughter and my mother. And my mother, I had the good fortune of having lived with me for the last 5 years of her life. And so I learned, well, I had my daughter all that time too, children's sleep, my mother's sleep, what happens when you age, and got firsthand experience with all of that. And the disorders that can come too as we age with sleep, because my mother had Alzheimer's. So she experienced a lot of sleep dysfunction and REM behavior disorder where she'd move in her sleep or she couldn't sleep well and she'd sundown. So she really crashed at night. And then it's my daughter. My daughter would climb into bed with her all the time. And even though my mother would sometimes kind of flare out, my daughter would sometimes climb back up into my bed at 3 o'clock in the morning and say, "Grandmommy's hitting me." So she would leave her bed, but she loved being in there with her. And so that's why I wanted to show that as kind of an introduction.
Yeah. And it's like the seasons of life. Yeah. We have seasons, it sounds like, of sleep.
Yeah, we do.
And how things kind of go for us and different challenges in those different seasons.
We do.
So can we start off by maybe kind of level setting on some of the sleep disorders out there?
Yeah. So I want to talk about common sleep disorders. And Very common is insomnia. It's one of the most common, it is the most common sleep disorder. Apnea or sleep apnea, obstructive sleep apnea. Starts to change dramatically. Periodic limb movement, restless legs. If anyone's ever been pregnant before, restless legs is that restless, agitated feeling in your legs as you're falling asleep. Can often happen with iron deficiency, but also just from alcohol, tobacco, etc. But periodic limb movement can be a kicking disorder that will wake you up during the night. So we always want to make sure that we get that evaluated. Circadian rhythm, if anyone has a teenager, they know that one. That's difficulty getting up at the right times and, going to sleep at the right times. Teenagers, and I'll talk a little bit about this as it changes of life, definitely have more circadian rhythm problems than anybody else, but shift workers, big problem. And shift workers, nurses, etc., there's much higher rate of car accidents, motor vehicle accidents during a really critical time, which is about 2 to 3 a.m. when our brains are not working great. And it's very common that we have problems during that time. So even if you're not sleeping, your brain knows the time of day and knows you should be sleeping. So it's really important to understand that. Parasomnia in kids, we'll talk a little bit about nightmares, night terrors, which are not bad nightmares, but instead when people wake up screaming and yelling during the night, it's more common in little kids, sleepwalking, grinding your teeth. And I have voluntary sleep restriction in there because this is something really common for a lot of us, particularly moms and women, because you're doing so much, you do your work and then you do all the domestic work and then you get home and you're trying to preserve some time for yourself. I actually didn't think about this or ever process it until I had a child. Yeah. And then I started finding myself kind of staying up later than I should, just so I could like watch Netflix or read a book or something. And I think it's very common because it's your one little piece of time. People never volunteered this to me either until I started asking them, are you kind of not going to sleep because you don't want to, because you want to do something else? And then they were like, yeah, okay. Yeah. So that's not really insomnia, but it is for sleep, right? Yeah. But it's common.
Is super interesting about all of these in the wellness world is, and this is why I'm so excited you're talking about this today, Dr. Rose. There is so much marketing now and so much supplemental marketing and so much hype, if you will, that's my professional term, around each of these. And so we have this prevalence of melatonin in the supplement world. Has anyone taken melatonin ever? No judgment. So melatonin, and I'd love your take on this, Dr. Rose, can help you fall asleep and stay asleep. It's also a hormonal disruptor. And so it tells your body to stop producing natural melatonin. And I won't get too scientific with everything. So yeah, it's a great quick fix, but it's not the behavioral change we want to see in patients. It's not the lifestyle change that creates sustainability. What's really interesting is that the group base, the patient base for the sake of this talk that I work with is average age 28. And the incidence that I see the most is insomnia, that circadian rhythm disturbance, and voluntary sleep restriction, right? I think voluntary sleep restriction, I can always find 5 more minutes to watch a movie. Or 5 more minutes to put the laundry away, or 5 more minutes to do something, and then you pay for it in the morning. And there are so many fascinating behavioral changes that aren't super difficult to adopt. And I know you're going to talk about this in a minute, but just seem a little maybe out of our reach. Or how do I address this 5 more minutes at night? Or how do I address this circadian rhythm disturbance? And it's really fascinating to see how marketing has taken a space in selling us away from this instead of treating us with pretty manageable, sustainable ways, I feel, to get better at sleep.
Yeah. So Dr. Rose, I heard you say early on, especially when it comes to like the sleep apnea and trying to figure out if we have it, you mentioned doing sleep studies. So we hear about this. We've all heard of sleep studies. Maybe somebody in this room has done this before. Um, how do you know if you need a sleep study, and what is a sleep study? Like what's involved in that?
So a sleep study is called NPSG, nocturnal nighttime polysomnography, meaning looking at different features of sleep, several features of sleep, right? Things that are going on. And what we're doing really is to focus on whether or not there's a breathing disruption or kicking in your legs. Insomnia, we don't generally do an NPSG for, because then we'll be staring at you and you're staring at us all night. So there's no point in doing that for insomnia. So that's really a report-based thing. But the patient comes in, they get all hooked up on sensors that we put on their head so we can tell what's going on at different stages of their, like in their brain functioning, and whether or not they're asleep and what stage of sleep they're in. They get pulse oximetry so we can tell about their oxygen saturation, bands on their chest, it tells us about their breathing rates, sensor on their leg tells us about kicking. So, and we can look at them during the night and we can see you and hear you, and we can record all of those things and come up with pictures to whether or not the person has a breathing related sleep disorder. That's the most common one we'll see. If you have it the night of your study, chances are you pretty much have it. If you didn't have insomnia on the night of a study, it doesn't mean you don't have insomnia. It just means it was a different environment, et cetera. And kicking, usually we'll see if person has a kicking disorder, it's pretty consistent, unless it's only because they drink a lot of caffeine and they only do that occasionally, you know? And then in the morning, the physician will read the study and be able to write up a report. So someone knows if they have a need to evaluate this, if they are snoring loudly, particularly if you can hear them in the other room. And so I've had many patients who report that. If you can hear someone snoring in another room, that's very disrupted breathing. If anyone sees pauses in their breathing, if you have, a hypertension, so high blood pressure is hypertension, diabetes, any history of stroke, cardiac disease, all of those set you up for greater likelihood of sleep apnea. And as we get older, and as we get older as women, our risks really increase. All of this stuff starts to get, hang down a little bit more. We don't have as much muscle tone, and that kind of tends to crowd our airway more. And we just don't have as much muscle tone, and we don't have as good an airway as we get older. So it's very important. Yeah.
Yeah. And is now the time to kind of talk about what actions can you take from this sleep study? I mean, it's great to have this information, but we're trying to fix the thing.
Right. So if someone has, and this is sleep disruption picture is my cat being disrupted by my child. But there's airway.
I love how you put that. The cat is being disrupted by the child, not the other way around.
Here's the eyes open like, oh my God. Yeah. So airway related sleep disorder is really very fixable. We have positive airway pressure, which is it's a mask that people wear, and it pushes room air, not oxygen necessarily, but room air to open the airway when it closes down. There are also there's a oral appliance that dentists can make that can open your airway. There is surgery. Sometimes there are surgical procedures people can get. So there are a lot of options. But what I tell people when they say, I don't want that thing on my face, which is often what they'll say, is, well, first let's just see what's going on. And then you can decide, and we can decide what other options you might have. Movement disorder like kicking can sometimes be iron deficiency. So we always think that, particularly young women, they menstruate, they lose iron, they're going to have more problems. And we want to keep your iron levels good. So that's important for us to know.
Casey, you shared that I was a ballerina. What's interesting, I found out I have severe anemia just by nature. And I found out from restless legs. And I was the most tired little girl, full of energy, if you will. And a sleep study actually is what revealed that. They didn't think to test my iron first, but they thought, what is going on? Like, where is this little girl running? And I will be forever grateful for that, because it changed my quality of sleep, but also B, it allowed me to understand the value of sleep in my health at such a young age, which I think is rare. I don't think as children we're ever like, got to get my 8 hours, but that changed everything for me.
Well, and I think as parents, or as adults, we don't value sleep. And so I can see where we would impart that on young people, where we will often say things like almost like a badge of honor, I get up at 5 a.m. and I work out, I do this, and no, I'm going to stay up till midnight. And, we all know young people see everything that we say, they listen to it. even if we're not intending it as a lesson.
I think that's true. And the iron, it's important that you think about how the daytime, and I'll talk about this a little bit, everything in the daytime is impacting your sleep at night. It's not isolated. It's not just what happens at night is
Mhm.
going to affect my sleep. And like the iron deficiency was important because that affects your neurological system too, and mood and a lot of things. So finding that from that symptom of the restless legs and the periodic limb movement was critical that they do that.
Yeah. And I warned Dr. Rose of this too. So bear with me. I have a little bit of a namaste science on things, but I promise it's science nevertheless. When I started graduate school, I learned a little bit about Ayurvedic medicine. I don't know if you've ever studied it or looked at it. It's the world's first ever form of medicine. And the emphasis on acknowledging circadian rhythm is profound. And I love what you said about what happens during the day affects what happens at night. And Ayurvedic medicine looks at literally everything you eat, what time of day you eat it, what temperature it is, and how this all not just fuels your day, but fuels your night so that your sleep is as qualitative as your waking hours. And that was something that totally changed my life in respect of circadian rhythm and avoiding, right, needing more care there in this sleep kind of absent space.
And we know that everything has a circadian, every living thing has a circadian pattern. So cyanobacteria, which is our origin, it's the first form of life form, has a circadian pattern. So we do. And we are very, very driven by that. And evolutionarily, there are reasons for it.
Mhm.
That there are some animals that are diurnal. There are some animals that are nocturnal at night. There's some that are crepuscular, meaning that they do things right at the dawn and dusk. And that's very intensely ingrained. And evolutionarily, there's good reasons for that too.
Do you believe that, and there's so much science conflicting around all of this. Sorry, Casey, I'm doing your job for a second.
Well, it's right. I gave you a title of like director of communications, so you're on it.
Do you believe that each human has a similar circadian rhythm, or do you, I know we were talking about shift workers, but do you believe scientifically we are awake during the day, we are asleep during the night, or do you feel that we're evolving into more specific patterns?
No, we're not. We're not evolving differently, really. I mean,
Okay.
we're not evolving because there's no selection for that, right? So really, but we do have, certainly we have people who are a little bit better towards the nighttime.
Mhm.
So again, if we think though, in terms of evolution, I think you have to think about some had to be sentinels, to protect the others. So people who were more predisposed to be able to do that, did that. But we know that the cortisol levels and melatonin levels and everything are very strong drivers. So we are most certainly diurnal.
Mhm.
And there's some people who reverse their schedule because they want to for whatever reason. And we have to have people who are in hospitals and,
Yeah.
running
And
ambulances
running
and
sleep
police.
studies.
And- right, exactly. My tax. And we have to have people who can do these things at night. It doesn't mean it's good for them. And in fact, when we look at like nursing, there's been studies on nurses who are longer term night workers. They do have a higher rate of cancer. They do have a higher rate of high blood pressure, et cetera. And it affects the GI system and everything else. But we have to have people who do some of these jobs. But no, we are diurnal, and we generally, and agriculture is different, but in the US, we're not very good with sleep. But some countries like Japan are even worse, with how much sleep time people have. Yeah, it's very, very curtailed.
So let's jump into some of the things that you hear that women tell you about sleep.
Right.
Women have a little, to generalize, but you definitely hear some different things from women.
Yeah, it's interesting, the report, when we look at difference between men and women. So women do report having less sleep, at longer time to fall asleep, poor sleep in bed. It's interesting though, when we look at them just through like actigraphy, meaning which is motion sensor. So your phone, I mean your watch, when it tells you how your sleep is really looking at your motion. Motion is highly related to sleep. So it's interesting because women, when we really look at them, don't seem to have those. That's not what seems to be going on. However, it's experienced like that. And that's what insomnia is about. The other thing is, I think a lot of women, though, their mind is still active. So even if they're not moving a lot, there's too much worry, there's too much activity at night. And so that's disrupting them. A lot of women I speak to say they look over at the bed and their husband's out. He gets into the bed and he's completely out, which is not necessarily great, because if you fall asleep immediately, probably sleep deprived. So that's also not good. Yeah.
Dr. Rose, what do you think? My encouragement often is night meditation, right? Pre-bed work. So yeah, I concern myself a lot with that quick latency, right? You just fall asleep immediately, but then again, none of us want to just be lying there worrying about how long it's taking us to fall
Right.
asleep. What do you think about those more non-traditional methods like a sleep meditation or a sleep app? Because that is something I like to share. What do you think about that?
Those are great ways to kind of to facilitate sleep. And some people do really well with white noise, and we know it drowns out other things and it keeps that sudden punch of sound. So again, if we go back to evolution, we wanted to be able to hear anything that was worrisome in the environment, right? And anything new that we're not used to. So if you have a cat, and if you have a bunch of cats, let's say, and you hear scratching at your door, you probably won't wake up. But if you don't have a cat and something's scratching at your door at night, that's going to wake you up. Same volume, same sound. So we do respond. Our brain remains active during the night. We are never totally dead unconscious, but we want to put it in a state of a peacefulness, not shutting off, but peacefulness. So I never talk about shutting down at night. I talk about winding down and kind of learning to put your brain where you want your brain to go. And those techniques are extremely beneficial. And anything really that you bring to bed with you that's worrisome, if you can't just ignore things from the day that are really bothersome to you and then just fall asleep, because your brain in a protective way is saying, no way. You did not deal with like your brother who's in jail. You got to deal with this stuff. So until you do, I'm not letting you sleep. So in some ways, it's not necessarily our body being against us or out of control. It's our body trying to tell us something. And that's really important.
So let's talk a little bit about, we talked early on about, how we have these stages of life, and that also can bring with it different stages of sleep, great sleep, sleep issues. So let's kind of run through a little bit of that.
Yeah, I want to talk about different stages and the major things of disorders that we look at, and also kind of the things that contribute to that. So you look at middle school, I think about what we see mostly as nightmares really common. The middle school children start to have more anxiety about things. They start to think about the world differently. Sleepwalking, bedwetting, and insomnia, what's called insomnia of childhood, which is usually that they just won't go to bed, or they get up a lot during the night, or there's a lot of behavioral things that are going on with them. And those are the most common disorders for children. And they're relatively treatable. I mean, insomnia of childhood, we just need routine, and we need to make sure that we know there's nothing else going on with children. In teens, it's more circadian rhythm disorder and sleepiness. They just can't wake up, right, for school. And they have lots of problems with circadian rhythm because their natural melatonin that we talked about earlier is produced about 2 hours later than ours is. So they want to go to bed later and they want to get up later. And then because they become habitually sleep deprived, they are sleeping in late because they're trying desperately to catch up.
If we have that science, look, this is me going back.
I was about to say the same thing.
Why don't we just start school later? Look, 15-year-old me is like, yes, preach. Why are we having children start school at 7:30 a.m.?
It's funny that you asked.
Not your fault, Dr. Rose.
No, but in some ways it becomes our fault because we've got to make change. So it's funny that you say that, because there are some states that have implemented laws and they're starting the high schools later. So that started in Rhode Island. So Rhode Island, there's a wonderful adolescent researcher, Mary Carskaden, and she's done a lot of research on melatonin in teens and found that their melatonin levels at the time that they go to school is where our melatonin levels are at about 3 a.m.
Oh my gosh.
It's very dangerous. They have they have car accidents, and they're not drunk when they go to school. They have car accidents more often. And we know they fall asleep at the wheel. Sports related injuries from early sports, because sometimes those kids are not only starting school at 7:30, they have hockey practice at 6.
Yeah.
Which is they're not prepared to do it. Their body does not want to do it at that time. And then they've been doing homework all night too. So the situation with teenagers is troublesome. But in Rhode Island, where they changed it to about a 9 a.m. start date, what they found, everyone said, oh, well, then the kids are just going to go to sleep later. Well, the children do go to sleep a little bit later, but they not that much later. So they still were acquiring a lot more sleep, and GPAs went up.
Wow.
Yeah, in the public schools. So we know it's important, because if they don't get sleep, they don't consolidate memory. It's really important. Yeah.
I love this.
Yeah. It's fascinating.
I got some things to bring to the next board meeting, And then we talked a little bit about being pregnant, and that obviously that creates a whole new world.
Yeah. And that's a big one, because when you're pregnant, it's like you have this temporary sleep apnea sometimes too, or snoring. And it's like, do we treat it? There's been a debate in our field too about what do we do? Do we think we just treat it for a couple months or whatever, and we generally don't, but your weight, you've got that extra weight on you. You've got, so you start to snore and you're not breathing as well. And it's more of a struggle. Nocturia, you're waking up using the bathroom all night, which any of us who've been pregnant know. You're sleepy. So progesterone is the hormone you produce at that first trimester, right? And you get hammered with that and then you're just out, and then middle wakes again, for a variety of reasons, your sleep just gets more fragmented. So pregnancy is another time that, yes, is different things that come up at different stages of our life.
Before you go into postpartum, I'm glad you brought up middle wakes. There's so much, I don't know if any of you have read this, and I'd love to know your take, Dr. Rose. There is so much conflicting science on it's okay. I know for me, I used to feel like a failure if I woke up at 3 a.m. and went to the restroom.
Right.
There's now science revealing that that's actually natural and normal, as long as we don't get paranoid and say like, oh my gosh, I'm awake. I'm not going to be able to fall back asleep, that's actually good for us or protective. What do you think about that?
Absolutely. And I think I've had a lot of patients who say, I don't want to wake up at that time anymore. What happens is it is natural after you've dissipated like that first 4 or 5 hours of sleep. That's when you've had the most critical amount of sleep. It doesn't mean you're done, but it means that you got the bulk. And now your system says, again, if we think about evolution, check your environment, make sure everybody hasn't left the cave. Or there's no, there isn't some, giant tiger coming in or anything. So then you wake up, you kind of check your environment. So most of us, if we don't have insomnia, we'll do that. And some of us will wake up, I wake up a lot, but I know they're brief. And then I will use the bathroom or I won't use the bathroom, whatever. But because I'm not worried about it and I know I'll get back to sleep, I'm okay. What happens is if you assume just exactly what you just said, you wake up and you're like, oh no, I'm not going to go back to sleep. Oh, I'm not going to be able to work tomorrow. I'm going to crash my car. You become catastrophic about it and you start anticipating it. That's the killer, right? So that is really you are creating a self-fulfilling prophecy. So even if, that's happened a lot, last 5 nights I've woken up and I didn't get back to sleep and it was really bad. Okay. It doesn't mean it has to happen that way. It doesn't mean it's going to keep happening that way every night. So that's a very important piece. But it is natural to wake up, but it's natural to wake up briefly and then to return to sleep. When people can't do that, that's where we have a problem. And we need to really work with them to try and improve it. Yeah.
Thank you.
No, I remember when you told me that.
Yeah.
And I was like, wait, I can just quit stressing about it?
Yes.
Yeah, absolutely.
Wait a minute. I can wake up and be like, okay with it and go back to sleep.
Yeah.
It's like giving yourself permission, not to make it a thing.
Well, and I feel like that's pretty new. Like most people haven't been talking about that a lot because I think we got this notion really hammered into our minds of 8 hours of sleep and this is what it must look like and this much REM and this much deep sleep. And certainly, yes, to the science to all of that. And I'm so grateful you brought up the point of mentally, it makes a ton of sense for us to be like, oh, wait, is everything still cool? It is. All right, I'm going to take a little lap or let the dog out or run to the restroom, whatever it is, and peacefully fall back asleep.
Right. And again, for those of us who have been parents, a part of our brain being so active is that we know if their baby kind of peeps in the other room, if you're the provider for the night, it's been designated, you're going to do it, you're going to take care of the baby. The parent who has that designation will wake up while the other parent just sleeps right through it. So that's been another source for couples too, of like, how can he sleep through her screaming? And it's like, because it's not his job right now. If he has another day, it is his job, but our systems are really trained like that. Yeah. Which goes to postpartum, right?
Oh yeah.
I love it. Take us through it.
Yeah. So postpartum, of course, is going to be associated with lack of sleep and insomnia, sleeping excessive hours too. So it can go either way with postpartum. Restless legs, again, for iron deficiency, sleep apnea, because you still have some of that weight, and still using the bathroom. So a lot of the same issues that come up with pregnancy are still there during postpartum. But the baby care is the big thing. So, and that sense that we are supposed to do all of that. So I know when I had my baby and I was postpartum and I was trying to nurse her, and she literally, I had the person I had was going to fill in and help me and take care of her. The baby just started like rolling out of my arms and I was becoming unconscious, and she kind of was sitting right there and took the baby and she said, how about if I feed the baby, because I was so dead tired. And so postpartum is really difficult. And then depression can set in, even though you've had this wonderful thing with this baby, it's still, very, very stressful. And so it can be terrible.
Yeah. And this is kind of the second time I've heard you talk about this relationship between sleep and depression. Can we, I don't know if it's in the slides technically, but can we take just a second, kind of talk a little bit about that?
Yeah, it's a really good point. There's a very strong relationship because when we have depression, our sleep is a circular relationship, right? So our sleep becomes disrupted. And when our sleep is disrupted, we become depressed and anxious. And so, but we know that we have to treat both of those things. We can't just say, oh, we're going to treat depression and poof, your insomnia will go away. Our researchers at Menninger found that that's not at all the case too, that if we don't treat, if we have inpatients who have depression, anxiety, and we don't treat the sleep problem also, then when they go home, there's a greater rate of relapse for anxiety and depression. So we must, even if they looked fine, anxiety and depression is well managed, you go home. If they're still not sleeping well, it's really problematic. We know too that fatigue, and I'll talk a little bit about differentiating fatigue and sleepiness, that just being worn out, whether it's sleepiness or fatigue, is also a really important predictor for relapse, for mood disorder, and for suicide. So we really have to get people up and moving. That's absolutely essential. And that can, in depression, it just sets in and you're always in bed, right? When you have major depression.
Well, and I think there's another piece on the wellness side too, that we add to that circle, and that's weight gain or weight loss typically presents as obesity or weight gain, which makes it harder to sleep, which makes us more depressed, which leads to more weight gain. And if not fully treated holistically, it's like you said, we're kind of robbing Paul to pay Peter. We're filling one gap only to have another gap get wider.
You're absolutely right. We can't just say, we look at apnea and that's it. You have apnea, take a machine, go home. If we do that, then people get mad because it's like, I didn't come in here for apnea. I came in here because I don't sleep, and it's like, no one talked to them about that or help them understand that. The other thing is just looking at the wellness piece and the weight gain reflux. So that people have nocturnal reflux at night, that acid reflux, and particularly when you're postpartum and pregnant, and then you can have apnea and you aspirate that, or it just sits in your, it's terrible. So we've got to look at this comprehensively. And a lot of people who have sleep apnea or any of these other things also have insomnia. And if you don't address that, then it just leaves them frustrated because it's more complex.
It's so great that you're bringing this up. I read, I love this book. I would love to know your take on it, The Sleep Solution.
Okay.
But Dr. Winter shares that after he did his research, I'm going to read this quote for you all. Most physicians have received less than 2 hours of training about the entire field of sleep in their 4 years of medical education. And that blew my mind. Again, thinking from the wellness side, like we need food, oxygen, sleep, and this is 2 hours of the education process.
No, it's a huge problem. And we're in the programs where they have good sleep programs, the medical schools that have good sleep programs. If their professors that are in those sleep programs are also educators, then they will often be able to do additional lecturing, bring on medical students, et cetera. And that's the time when you want to catch them early on. But no, that's appalling it is, but it's very, very little time. And it's hard though, because physicians have very little time for a lot of other things too, so it's very tight. Yeah. But so moving from postpartum, we move right into parenting years, which don't get a whole lot better.
I know Dr. Rose and I were both talking, both of our daughters are the same age. They're both 9. So I think we're getting a little better right now with sleep, right?
Yeah.
This is that good age. They're sleeping on their own.
Yeah.
Not waking up too much. Not too much stress yet.
And again, though, too, they still go through I'm not sleeping, and then they're out, right? So there's the fight sometimes if there's something they think they might miss, right? So during the parenting years, we have lack of sleep, we have insomnia, and we have lack of sleep too, because we've got teenagers coming and going, and they might have shift workers for a partner. And I know too that there are a lot of people who feel like they have to be the sentinel and make sure everyone else is asleep before they can go to bed. So moms or dads, and they don't know why. It's like, it's instinctive, right? That you can't go to sleep until everybody else is asleep. When you have teenagers, that's like not easy.
That seems smart, frankly, but
no, right. And again, elective sleep deprivation, right? Like you don't have that choice when you're postpartum because you're so out of it and tired. But in those parenting years, then while you're running around the day doing stuff with the kids, you want just a few minutes to yourself. And so then you take even more out from your sleep.
So let's talk a little bit about menopause. That creates that's a whole new world.
Yeah, it is. And
Big
so
changes.
sleep apnea is really common, and then nocturia, early morning wakes. So as we get older too, our schedule shifts. So it shifts back. So in adolescence, you want to go to bed later, wake up or later. And as we get elderly, become elderly, we want to go to bed earlier and wake up earlier. That napping that you see people who are older doing too, that's not necessarily normal. I mean, it's a joke that they always say, oh, old people like fall asleep all the time. A lot of the times because they have untreated apnea or they're not getting enough sleep at night. A healthy person in their 70s or 80s doesn't need to nap during the day. So little children do because their circadian pattern dictates it. But when we're
So
older, we don't need it.
interesting. I had no idea. I thought that's just what happened when you got older.
It's largely because people have untreated apnea or other things. And it's interesting because there is a question on one of the board exams in the past that said that I'm not giving it away for anything but it said who is more likely to have difficulty if they're sleep deprived with functioning during the day, this old person or this young person. And it's the young person. The older person has learned compensatory mechanisms, and they're more able to function and learn things better if have the same sleep deprivation as a young person. Yeah, and you wouldn't think that because everyone thinks, oh, well, the young person can overcome everything. It's like not necessarily true.
Speaking to menopause, thoughts on progesterone and how that decreases, because that is such a key element of our sleep. Do you think subsidizing progesterone or again, I'm not a big melatonin gal, but what do you think that offers as far as quality or even quantity of sleep?
So progesterone, estrogen, all of those are hormones. So I think we have to be careful with it. Yes, progesterone does tend to help us get sleepier, but I'm not a physician. I don't know what happens if you get kind of overloaded on those things.
Yeah.
I'm of the mind that we really need to figure out what else is going on. It might not just be hormonal. Some people go through menopause and they don't have a lot of problems. Some people do. And whether or not that's hormones or other chemical changes or life changes is hard to know. So it's very difficult to answer that. And with the melatonin, a lot of the time, even you can get over-the-counter melatonin. It's like 10 milligrams, which is a huge bolus. And there is big company in town that sells a bottle that has 10 milligrams. And it's crazy because it's really not at all what is recommended. So we usually tell people 1 to 5, no more than 1 to 5 milligrams per night if you're going to use it, and still under direction of a physician because you never know what can interact with what.
Yeah.
But we have people I take 5, and then if it doesn't work, I take another 5, and I take another 5, and we know that long-term, particularly long-term use of melatonin, 10 milligrams or more has been found to shut off receptors.
Yeah.
And you just can't overload your brain receptors with drugs.
Thank you for talking about this because again, like I said, and again, I take more of the wellness science approach, but I think in wellness, we get kind of these buzzwords like, oh, melatonin, or, oh, Gwyneth Paltrow recommended this tea that does things. And
that sounds like good medical advice.
Yeah. and here we are all subscribing to it because I think of a lack of information. And that's certainly not an admonishment on anybody. We just want to be better. And that's why the work you do, Dr. Rose, is so incredible because sleep, again, that is our key physical wellness piece that we forget about outside of nutrition and movement. And we just throw things at it and see what sticks. So I'm so grateful you're sharing this.
Thank you. Yeah, no, I think it's a really good point. And in general, people try lots of different, it's so many different kinds of things and mixtures and elixirs. And I think what's critical to know is there isn't any single magic bullet for anything. So when people take medications that are pretty heavy duty for insomnia, those can be very habit forming. It says right there in the bottle too, don't take this more than 8 days. But a lot of people are on them for years and they can make you foggy, feel foggy, and they don't really address if you have a bad marriage, Ambien won't fix it, So you've really got to address the thing that's causing the problem.
Petition to put that on a bumper sticker.
Yeah.
Ambien will not fix your bad marriage.
That's right. That's right. But you're desperate.
Yeah.
And so, yeah.
You lose enough sleep, you get real desperate.
Yeah.
Absolutely.
Yeah.
Hey, I'd love to jump ahead a little bit because not shockingly, the three of us are going to just talk a lot. Can we jump ahead a few slides? I'd love to get into some of these sleep-related airway signs in kids.
Yes.
Yeah.
Let's jump ahead to that a little bit and just
Right.
kind of touch on that because I think this is something
Okay.
I don't
And everybody
think
has
of
to
this
read
for
those
kids.
super quick because those are all the different causes at different ages
Well,
that cause sleep
I think
disturbance.
we kind of talked
We did
through
talk through a
those.
lot of
Yeah,
it,
we
yeah.
talked through a lot of that.
So we've got, and then this one is this is just real quick, that is a major cause across the lifespan of sleep disturbance. So we have people all ages waking up because, you've got pets to feed or let out or the snoring. They can be wonderful though too, because we co-sleep with them and they can give us warmth and comfort and friendliness, but I've just had to have that picture to show across the lifespan.
Is that your schnoodle?
It is my schnoodle.
Okay.
Yes, it is my
What's your
schnoodle.
schnoodle's name?
Chloe.
Chloe.
Because Chloe was the goddess of fertility, and Chloe, my dog, was very good at fertilizing things when we first got her.
Oh no.
Yeah.
Go, Chloe.
Yeah.
There we have it. There we have
Good
it.
at that. Yeah. So childhood, we talk about childhood insomnia real quick, and then you want me to move to shall I move to the sleep apnea? Okay. All right. So sleep apnea. What happened to that thing? There it is. Okay. So sleep-related air-related signs in kids are going to be things like grinding your teeth. Grinding your teeth in adults too is a sign that you're trying to open your airway to some degree. Not always, but it certainly can be. So talking in your sleep, even getting up and doing sleepwalking. When we have someone who sleepwalks, we always first evaluate their airway because we need to know, is your airway obstruction? It's because your bodies will tell you, you better wake up. And it will do anything. It will sleepwalk, it will thrash out, it will grind its teeth, your teeth, whatever. And so these are some common things that we see. And then also for symptoms when children are irritable, when they're snoring, again, that's the big one that goes into this funnel, right? When there's a lot of snoring, their airway is resisting. Some people think when children snore, it's kind of cute, but it's not ever cute. It's still an airway obstruction. So it has to be considered. And ADHD symptoms, it's a really common one. We often will see kids with ADHD and they've been put on, and this is difficult because they get put on methylphenidate, they get put on amphetamines, which is okay if they're really truly needed. I was just talking to a psychiatrist last night that I know well, that I hadn't talked to in a while. He called and he was talking to me about ADHD in kids and how overprescribed these medications are for kids. And so this is way children manifest airway problems is they look very ADHD. And the only way to rule this out is to do a sleep study, make sure that they're breathing okay, and then a proper neuropsych evaluation, with someone like our friends,
Yeah.
to see if they really have these symptoms broadly.
I'm so glad you brought this up. So ADHD is a buzz phrase in the wellness world right now. I don't know if you all know this, but it's very popular now to have ADHD. I'm not sure. I am sure why psychologically, but that's a whole other road. And I'm noticing, again, this overprescription of, and I never want to vilify prescription medicine. I think it has so much value,
Right.
thankful for it always. And you can call your psychiatrist, say, I think I have ADHD. Your psychiatrist will ask you a few questions, and then you're on this very high stimulant,
Yeah.
and then you're not getting quality sleep, and then you are presenting with ADHD symptoms, and then you are dependent on your medication. And it goes back to that cycle that you mentioned of it really is so holistic. And are we looking at every single indicator, even on this funnel here, not just within children, but with any adult patient?
It can be, and so those medications or stimulants can be a game changer for a child who truly has it.
Yes.
They have to be well evaluated, not some screener that someone takes 10 minutes to do.
Yes.
Because the crossover between ADHD and depression, they look a lot alike. And
Yeah.
so if you look at depression, ADHD, and sleep apnea, they look a lot alike. You got to know what you're treating. It's really important. But yes, but they can be very helpful. But those medications also can be cardiotoxic, and then trying to get them people off it is very
Right.
hard. So we have to be selective. Yeah.
Cardiotoxic, just for our viewers, will you explain that?
Oh, that it's hard on the heart.
Right.
It's not good for the heart. So if you truly need it, changes your life, then a doctor who's careful about its prescription. But people who are taking it for college, I mean, there are people who take it in order to perform better in college. Adderall is highly abused by college and high school students. And sometimes when kids are doing, like I've had teenagers before, they're just doing too much stuff. You can't do 4 hours of homework every night, 3 hours of band and 3 hours of sports, and then, say, what am I going to do? And not listen to cutting back on anything.
Yeah. And I think that's similar with young adult patients. Even it's like, okay, well, why am I so tired? Even though I'm waking up and I'm still trying to get the same workout schedule I had in undergraduate school,
Right.
and I'm working 9 to 10 hours, and I'm going to my happy hour because that's what I'm supposed to do because I'm 25 and I go to happy hour. And why am I so exhausted? Or why is my brain not functioning? It's like, well, I'm exhausted listening to you. Right. I mean,
Right.
it's so interfering in just a natural rhythm.
Right. No, I had a teenager the other day who told me, well, I get 4 hours of sleep, but everyone I know does.
Oh,
Like, do you think that's normal? And he was like, yeah. And I said, no, it's not. So, but that becomes a norm. You just supplement, you fall asleep in your classroom, and then you get drugs, you know?
yep.
Yeah.
All right. So let's jump to some postpartum things that you're seeing with everybody.
Okay. And postpartum, very interesting data on this.
Yeah.
About 84%, and this was kind of, I didn't know how to slice this in for the timelines properly, but 84% have insomnia at least a few nights per week.
Yeah.
42%, very common, don't ever get good sleep. And depression is really common. And it now I think OB-GYNs are much, much better at
Yeah.
picking up on this and not just blowing it off. And so getting people properly evaluated. And it's so tragic because you miss those first few months. It's terrible with your child, and you're bonding and they're bonding with you. And so we have to identify that very rapidly.
Yeah, and Melanie, I know you work with our entire population of professionals, many of them women at Alliant Group. I know there's women out there watching who
Mhm.
have careers and little ones at home. How do you kind of tackle some of these with our women professionals?
Case by case. I
Yeah,
mean,
I know every person's so
so
different.
different. I think, and this is again a little bit namaste of me, truly talking through it. Hey, are we being realistic? First of all, what does your schedule look like? Again, it's like the student with 4 hours of sleep a night. Hey, has anyone shared with you that's not sustainable? Has anyone talked with you about maybe adjusting your schedule? Why are you so rigid about this is what time I must get to work? This is what time I must leave? Have you talked to your boss about shifting things by 90 minutes can be a game changer. I have found, particularly when it comes to, I'm so grateful for your stat of driving drowsy with children in the car, because it's something that I know you all are moms. I am not, but you've got to get where you're going. And we are a car dependent society. And there's so many minor alterations to lifestyle that can be made for a major outcome to reduce that 20%.
One of the things I feel like we keep hearing in our discussion today is this almost, you mentioned it with the teenagers in the 4 hours. We hear it with the postpartum parent or mom who is, just like, well, this is what I'm doing. How do we make it the other way? How do we get to the point where it's the badge of honor to say, I got so much great sleep, or I didn't go to that happy hour last night so I could prioritize my health? Is that just like la la land for me to think like that?
No, I think it's a really great point. And I think it's driven by what we do, you
Mhm.
know, and how we feed some of this stuff. So trying to make sure that we recognize that these healthy behaviors are something to be proud of and to share, and not a badge of honor. Sleep deprivation, things of hardship. I think that we've always really appreciated redemption, right, and hardship, but we also have to put that in the context, right, of recognizing that redemption. Now you've changed things. You are going to sleep better. You're going to take care of yourself better, because I think that separation is really hard for parents too, where it's like, but if you crash, everybody crashes in the
Yeah.
family. So you can't just continue to ignore your own health.
Yeah, I had a colleague in graduate school, Amanda Bueller, and she would always say, you're no good to anyone else if you're no good to yourself. And I remember, this is a little embarrassing, but I used to think, yeah, that's for other people, right? And to your point, it's this badge of honor. And I guess maybe as I came into my 40s, I found that was just not appealing to me anymore. And my colleague Scarlett is in the back of the room, but even she was telling me her marathon schedule. And this woman lives a marathon life. And I just remember saying to her, like, okay, talk to me about how Friday is going to feel, right? And I think it's to your point, Dr. Rose, just talking about it. Hey, Casey, talk to me about what's October looking like, right? Or what is your rest or your downtime? And one thing that reminds me of is rest is also valuable. I think one thing for me, because I am so militant, I used to get really worried about sleep. And I remember, and it was our friend and colleague, Dr. Catherine O'Brien, who taught me, Mel, if you're just resting, even if you're just lying there, slowing down, that still helps you. And I think just breaking the stigma of it being a badge of honor, but also breaking the stigma of what quality sleep has to look like, helps some of us who carried it as a badge of honor transition it into something that is restorative, that makes tonight better for tomorrow's outcome.
Oh, I love that.
I think you're absolutely right. Yeah. So that's a key thing. That's absolutely key. Yeah.
So how about if we jump ahead to insomnia treatment? So it's a
Okay.
few slides ahead, because we love a good solution around here.
Okay.
Give me a solution.
So insomnia treatment. So one of the first things is being introspective and looking at what is my schedule, what can I change? And that flexibility is really important. And having that noticing, knowing how that impacts you every day. So that's all extremely important. But we think about stimulus control is a simple piece to all treatments for cognitive behavioral treatments for insomnia, which means don't do stuff in your bed that isn't sleep related. So the only thing you do is intimacy. That's the only thing you should do in your bed that's not sleep related. And we really say that. And the only reason why we say that's okay is because it would be dangerous to do it in the kitchen. So stay in, stay in the bedroom and do it. And then compression, we think about sleep compression or sleep restriction. I usually use what's called compression. So you reduce the time that you're in bed and increase that it helps that drive, that homeostatic, that natural drive that you have to sleep. And improves how much time that you're in bed that you're actually sleeping. That takes away that association with the bed as a place to be awake or worrying, because that's really deadly. Because if every time you go into your bedroom, and a lot of people with insomnia start to get really anxious when they start to go to their bed because they anticipate this is going to be bad. I'm going to have a terrible time. And then it escalates, right? So it's critical that you have that piece there. And so cognitive therapy really assists you and your family and everybody else. So cognitive therapy is a really important piece, which is, what am I thinking about? What just happened in my mind? So instead of letting yourself go down the same path every time of I'm worried about my mortgage, say, okay, is this a time to be worrying about that? No, it's not good timing for me. But also in the daytime, you set that time aside when our natural rhythm, like 9, 10 a.m., which normally would be the time that we were doing some preparation for hunting and gathering, right? That you look at that time and you say, what's the stuff that's going to come and get me tonight? So kind of theoretically, what is that tiger or wolf that's going to come into the cave, right? So you have to identify that and then say, okay, this is my plan of action. Not going to solve the problem, but it's a start. That kind of gives you permission then to be able to sleep and go to sleep that night. And taking that pressure off is really important. Also, being able to say, I'm going to do relaxation exercises, practicing those in the daytime, whatever they are, early in the daytime, throughout the day, and not just saying, I'm going to wait until I'm getting into bed and I'm annoyed, and then I'm going to try it. That does not work. So you got to get them. Yeah, exactly. And then you're frustrated more, and then you come back.
I'm going to try that meditation Mel's been telling me about right now at 10:30 when I can't sleep.
But then you come back and you're like, it doesn't work. It's like,
yeah, Mel.
Okay, all right.
I hear this all the time. And I'm glad you're bringing this up because, we always say like throw an app at it or throw a 5-minute meditation. Right. And I'm so glad you're bringing this up. And look, it's a great place to start. This is,
I never not at 10:30 when you're already frustrated.
It started at 10:30 and realized that's not working. Mm-hmm. And instead of getting mad at yourself or mad at the technique, readdress the timing or the approach. And so I'm taking notes along with our participants. I love that you shared what's going to get me tonight and tackle that in that really morning hour when we would normally take on the day.
Right.
And then how do I want to feel about that? Okay, right now I'm going to address this and move forward. And then at night, when it starts creeping back in, I'm already going to have that behavioral pattern that's going to help me address it. And it's not going to be out of nowhere.
Right. And the thing is too, that people don't understand, it's not like taking a pill. I mean, we can't, we're not going to go and meditate tomorrow and do it like she does it, because we haven't done it much, so it's a learning thing. You're learning new pathways in your brain. You're trying to learn to slow your heart rate and a lot of things, make physiological changes. So that's critical that people understand. This is not a single, you don't do it once and it's like, it doesn't work. I'm broken.
Or yay, now I'm a pro. And so many people think meditation or relaxation techniques are to empty your mind. They are not. If you think of And if you have another analogy for this, Dr. Rose, I'd love to know yours. What I always share is meditation is not to empty the mind of worry or thought. It's to create more space between worry and thought. So the way I always think of it is worry, thoughts, distractions, et cetera, as a cloud. I want more blue sky than I want clouds. Clouds move and shift, and they're temporary. They come and go. Thoughts are great. Thoughts, consciousness is what keeps us breathing, like you shared, right? We need to have thoughts. We don't ever want to turn those off. And we simply want to extend the time, even by a millisecond, of blue sky. And so when I meditate, I just think, okay, we are in a hurricane season up in here. How do I get to maybe a springier day? And it allows you to give a tangible behavioral change to now I'm seeking blue sky, but I won't vilify the clouds or the thoughts or the worry.
Oh, I love that.
I hope it helps.
I can really picture that.
It's a very good point. And I think
Yeah.
also redirection. I think about it in
Yes.
terms of redirection of thought, and being kind of metacognitive, meaning looking at your own thoughts and being able to say, why am I thinking that right now?
Yes.
Is this helpful? That kind of takes you out of the thought and helps redirect in an active way. So all these techniques are active relaxation. Passive relaxation are going to be things like, staring at a TV set or something. Those don't work as well as the things that you're talking about.
Yeah.
Yeah, those are highly effective. Yeah.
Yeah. And it allows you to take stigma off of it. That's my other favorite. Worry is fine. We were talking about this earlier, right? Worry is what keeps us alive and keeps us aware of the tiger or the panther or whatever could come after us. We don't want to vilify that. We just want to make sure we understand I'm worrying about this. This worry isn't helping me right now. Getting poor sleep isn't going to help me worry less. How can I put this worry? I mean, this is very gleeful to think, but how can I put this worry on pause and tackle it when I am best physically, mentally, emotionally able to address it? 10:30 at night isn't going to be that time. And I'm not mad at myself for thinking about it. And I'm not mad at the worry. This just isn't the time.
Right. Absolutely. So fear and anxiety motivate, but you don't want them to overwhelm.
Right.
Yeah, it's critical.
So let's talk about, we've gotten to the point where we know we need some help. We're not, the blue skies and clouds aren't getting it for us.
Right.
How do we find somebody? How do we figure out how to get some help?
Okay. Who knows who this is? You young people don't know this, really? You guys don't know who this is?
Princess
Yes, you do.
Leia,
Yeah, it's Princess Leia. Okay. So
Yeah,
this is when he's looking at the hologram, right? Help me, Obi-Wan Kenobi. As I get older, my eyes start dropping off my audience with these things, but but help me, Obi-Wan Kenobi, right? A plea for help, right? So what do you do? And so we talk about finding care, right? So find, if you're going to, for sleep, find a physician who's boarded in sleep medicine and someone who has some reputation. They're not just going to do sleep apnea tests on you. And if you're having problems with insomnia, they may be connected. Like a lot of physicians in town know about those of us who are boarded in sleep medicine. They work with us closely, that they will connect you to us if we can be of help. Collaboration, rapport is really important. So ask them why. So what am I going to do if I have apnea? Because I don't want this or I don't want that. And then they can answer those questions for you. And think about realistic goals. You're not going to change your sleep. Anything that makes you sleep. And this is always, you see this too. Like I'll have patients come in and say, oh, I took Seroquel last night, so I'm fixed because I slept really well. And I'm like, wow, okay, well, you probably don't want to be on that the rest of your life.
Right.
And even if you were, it's going to not work next week, maybe. So we don't know. So you have to be realistic with this. It's lots of things you have to change. You can't just change one thing. There's no elixir. Track your progress. Don't be hard on yourself. That's one of the most important things.
Yes.
Do not beat yourself up every time you can't sleep well, because that is completely non-productive. So you think about cognitive terms, you want to think about what's a functional thought? What's a dysfunctional thought? Dysfunctional isn't bad. It just means it's not working for you. So you might say, a functional thought, if you're in a house and it's on fire and you think the house is on fire, that's a functional thought. Get out of the house. But if you keep thinking it's on fire and it's not, that becomes a dysfunctional thought. So you have to go in the direction of, let me be realistic. Let me think about these in a way that I can actually make change. Yeah. And then just, think that your referring doc, so your apnea doc, your primary care doctor may say, oh, you have to go in because you have apnea, and it might be insomnia because they didn't have a lot of time to spend with you. And so it may be that there's something else in the picture that they will find. Yeah.
I noticed that one of your points is keeping a journal. And one of the things that Melanie insisted that we do today, and insisted in a good way, was put journals in front of you guys. So this is your giveaway. So those of you at home, I'm sorry, you have to go find a journal. But those of you that came to see us in person today, you're going to walk away with the journal. And why do you love journaling so much? What is your, because I know you're passionate about your journaling.
I am. I'm journaling in the moment right now. I think part of one reason we stay up at night is we wake up and we worry. If I don't worry about this right now, it won't get fixed. And that's super fair. Instead, jot it down. Don't pick up your phone. Because then that is a cascade of other distractions, right? Open up your journal and just write down illegibly. You will know it in the morning. Hey, remember to look at the rose bush out front. Whatever it is that wakes you up, right? Remember to ask Sally Sue's teacher about this thing that Sally brought up when we were doing homework tonight. And then, just like we talked about earlier, write it down, address it, acknowledge, oh, I can go back to sleep now. I am not afraid of forgetting this. I'm not afraid of going back to this when I am of more sound thought and awake.
And maybe even put it like in a cloud.
Yeah.
Put it in a cloud.
Throw it in the
Let
cloud.
the wind.
Yep. And
take
then
it
we're
away.
back to blue sky.
Yeah.
Yeah.
I love that. All right. So do we have, before we get to kind of wrapping it up, do we have a few questions? Are there any questions out there? Anybody have questions? Yes, Andrea.
What's good, what's not, what should be like an adult. Yeah, more on that.
Yeah, it's a good point you said, age. So the one group that we do want to nap who's adult are people with narcolepsy. That's a very specific and rare disorder, but because their circadian pattern, we get their sleep dissipated a little bit if they take that nap, and they can function better. Most of us should probably not nap. Now, in some places, we have that dip, that natural dip that most of us have right after lunch, right? That's pretty natural. And that's not just because we ate, it's because there's a natural dip. Again, if you think about evolution, we would plan our stuff and then we would dip and then we high sun, rest and then go out and do our stuff. So for adults, a lot of time we dip, and in other countries, that's a siesta, right? And so in Europe, a lot of the businesses will close for a few hours, but then they reopen and then they all stay up too late. So, so it's a problem too, but largely napping, if you are sleep deprived, and that's going to bring you a little bit more sleep during the day and it's short, I think that can work really well for you. But if you keep napping during the day, it's like snacking, it's going to affect your appetite. So if you nap a lot during the day, it's coming out of your nighttime sleep. So you want to be cautious of that. Also, waking up the wrong time, like waking up at noon, sometimes you feel that drag, you feel weird when you wake up too late. That goes back to that natural rhythm. Your body is saying you were supposed to have been up earlier doing stuff, so you can be thrown off with that as well.
And you mentioned earlier, the kind of the exception to that is children, right? Little
children,
kids.
it's very different because children need, and you cannot, there are people sometimes want, I'm going to change this baby. This baby is not going to get on a normal pattern. And they're really tiny. And it's like, no. Children need, and little babies, they go in and out of sleep. They're a kind of don't have much of a normal rhythm, and that's okay. That's what they need. Their body just went through a lot, you being born. And so you let them guide that. And then kids up until they're, sometimes a kid can give you the cues on it. 5 or 6 might need a nap during the day. So a lot of preschools and things will have that nap time for a little bit. Some kids won't nap, but most kids do need that, dissipate some of that, or they get really irritable and aggravated. Yeah. So
Anybody else have questions? Do we have any questions online? No questions, Thorn? Wow. Yes, Scarlett. Talk real loud for us, Scarlett. Yeah. So Scarlett's question for folks at home watching virtually are about eating before you go to bed. Are there good things to eat, bad things to eat? Cut off your food at a certain time before you go to bed?
Everybody's a little different with that. If you have reflux, the problem is that if you eat a lot, and our bodies don't want to do a lot of digestion while we're asleep. And so you lie down and then you don't have the gravity that you normally have that keeps everything where it belongs. So when you lie down, you can have more reflux. And so usually GI docs will say, don't, eat a couple hours before bed, but it depends if they're a very young person and the high metabolism, maybe that's a little different. But certainly if you have reflux, you want to be careful with that. And we don't really want to metabolize a lot while we're asleep. That being said, again, some people with rapid metabolisms or athletes, it's hard for them to get through the night if they don't eat 2 hours before bed. So it's variable. And what you eat, generally, GI docs will say, don't eat spicy foods anyway, like close to bedtime, et cetera. Anything that will aggravate, like GERD.
From a physiological space, one thing that I always love to share too is if you have to eat at night, this is also relevant if you take supplements at night. Like I know for me, I take a magnesium supplement at night. Just walk. If you can walk around your home for 10 minutes, that gentle gut motility will usher your food down, because I think a lot of times people are worried about the digestion piece, which is certainly, we want our body to rebuild at night, not spend its energy digesting. And sometimes that's not realistic. So if you can just get a gentle walk, I'm not saying pound the pavement, lace up the Asics, like just walk around your house, encourage gravity to do its thing, nudge that gut motility. It can help with that piece. I mentioned Ayurveda earlier. So Ayurvedic medicine says that our Agni, our fire, our metabolism is highest typically between the hours of about 11 a.m. and 4 p.m., depending on our type. I won't get into all of that. And you don't want to eat the bulk of your food outside of your metabolic fire anyway. It doesn't serve you as well. Not only will you have poor sleep, you'll have poor digestion. You will also have poor nutrient absorption. Your enzymes in your stomach are most effectively supporting nutrient absorption between that midday window. So you'll see most Ayurvedic practitioners or holistic physicians encourage patients to eat the biggest amount of food midday anyway.
Right. And I think speaking to that too, it's a very good point, because I think we know that movement is going to help with gut motility, and we're supposed to be moving. We're supposed to be moving a
Yes.
lot, and we just aren't anymore. So that's really problematic with digestion, and it's going to create
Well, and
problems.
it makes us harder for us to sleep, right? I think we kind of allude to this in other conversations, but if I run a marathon, to use Scarlett's lifestyle, I'm going to sleep way better than the days I don't, right? And we're just not moving anymore. And we're so sedentary with technology and all of that, and grateful for that. Grateful we have technology right now in this space, and we have to find those physiological ways to offset it.
Absolutely. Right.
So let's talk big takeaways. What do you want people to leave here knowing?
Know that what happens to you at night is not just about the night. It goes back to being able to have that healthy lifestyle during the day. And that's going to drive a lot. So if you're retired and you've got the blinds down in your house all day and you're watching TV all day, I don't think you're going to sleep well. You have to be active. We remain active our entire lives. And that's across the board. We need to remain active with our involvement with other people, with our intimacy, with our partners, et cetera. And that is not supposed to just drop off. We're social beings. Snoring is never normal. These are random major thoughts, but things I think about a lot. Family habits impact sleep. So if you've got a shift worker in the house and you've got a teenager who's out at night, et cetera, and you've got a child with a sleep disorder, then that's a problem. It's going to affect everybody. And then if you're falling asleep a lot in the daytime, something's really going wrong at night. So regardless of whatever your age is, unless you're a small child. And think about the range of things you have. You could have sleep apnea, and like I have a patient who has sleep apnea and narcolepsy and diabetes. I mean, all these things are connected, and then he doesn't always get to sleep on time because he's young, and so he has circadian rhythm issues. So think about comprehensively all of these things and how to manage those. But insomnia largely isn't one thing. It's not just this happened and then I have insomnia. You usually can't pick a date unless it was a massive trauma that you had during that time. But it's not one event. It's usually lots of different things and patterns that we get into.
Mel, you have some final thoughts for us?
I do. Sleep is for you. I think this is something we have come to see as a hill to climb. Sleep is climbing the hill with you. It is that third limb of physical wellness, along with nutrition and movement. It will always serve you. So just like you said, those metacognitive moments where you can say, oh, hey, I'm being mean to myself about not sleeping. Sleep and I are on the same team. We need to stay in this. And it's so much of what you said too, Dr. Rose, it's all interwoven. It's never just, I'm bad at sleep. My health is perfect in all these other spaces. And again, that's never a judgment on our health. In the wellness world, we never say unwell, we say wellness disruption. There's just a disruption somewhere. We need to get to the bottom of it. And chances are it could help your sleep. It will help your sleep.
My big takeaway is not to be so judgy. with yourself. Don't be so judgy with yourself.
That's a really good
I'm not
point.
the expert on the panel, but this is my takeaway over the last hour. Let's not be so judgy with ourselves. Let's cut ourselves a little break.
Absolutely. I
Yes.
think too much that we will say, oh, I'm so stupid. Why did I do that? Or why can't I sleep?
Yes.
And that's completely not productive and doesn't do anything to help you sleep. No.
Well, I want to thank you all for joining us. Those of you here physically with us, those of you virtually with us, Dr. Mary Rose, thank you so much. I
Thank
learned
you.
a lot today. Melanie Baxter, my colleague, my friend here at Alliant Group. Thank you, Alliant Group, for hosting us as well. I'd like to introduce Andrea Watkins with the Women's Fund. She's going to come up and do some wrap up for us and send us on our way.
Thank you, Casey. I really just want to piggyback off what she said. We are so appreciative of your time and making, you too, having a busy day and sharing your expertise with us. So we're very grateful for your time. And thank you for coming to our second Doc Talk. We are always so grateful that Alliant Group is so kind in having us and hosting us. I would like to thank our Doc Talk sponsor, the John P. McGovern Foundation, and also the Wendy Haskell Meyer Endowment. So the Women's Fund, have been around for over 35 years, providing information like this. Doc Talks are my favorite. You always leave so inspired. I'm going to go watch my sleep. I don't know how I can do that, but it's good to know this kind of information because sleep is vital. And so we do have some works for the next Doc Talk. We're kind of working out logistics, but again, thank you for tuning in. This will be on our YouTube page a week from now. So you can kind of rewatch this and share it if you'd like. And you can follow us on Instagram and Facebook to get more information about us. So again, thank you so much for attending.
Thanks, Andrea.
Thank
Thank
you.
you.